Hey everyone, Puneet here. Welcome back to the North of Patient podcast, Conversations on Health Beyond Care. This week's guest is the incredible Zayna Khayat, a health futurist for Deloitte Canada and a renowned go-to person for healthcare innovation. Among her many roles, she also teaches at the Rotman School of Management here at the University of Toronto and advises several healthcare startups. I've been lucky to know Zayna for over a decade. She was a key advisor during my first startup, Input Health, helping me navigate the startup building ecosystem, connecting me to key resources, and just being an honest mentor. And anyone who knows Zayna knows that she has a bold voice and she tells it as it is. So it shouldn't be a surprise that this episode is really about challenging dogmatic thinking in healthcare. We dive into some pretty big and provocative questions that many of us think about, but few dare to say out loud. Like, for example, is the traditional doctor patient relationship really sustainable for the future? In the wake of AI, will we really need discrete roles of different healthcare providers in the way that we define them today, such as docs, nurses, pharmacists, and so on? Or do we need to start thinking about a more fluid and adaptable health workforce? And lastly, can current healthcare systems really be salvaged, or do we need to think about building these pieces from scratch? It's not about right or wrong with these questions, but instead about giving ourselves a moment of pause and asking ourselves with honesty. So hang tight for an animated episode. Without further ado, here's episode 7 with Zayna Khayat. Zayna, I'm so excited to have you on the show. Welcome.
Love to be here, my friend.
Yeah, so this is a long time coming. I wanted to call out a couple of things right off the bat because I feel like this conversation in particular is very special to me. It's different from some of our other guests that I've had on the podcast where I'm getting to know people, but you and I have a storied history already. So I wanted to give some context for the listeners. You've been a mentor and a source of inspiration to me for a very long period of time. I think we connected almost a decade ago. You were working at Mars, at the Mars Innovation Center in Toronto, in the startup incubator community, on the health team. And I recall the support that you gave to Input Health, startup at the time, your support for our journey. I remember you gave us platforms to speak at, market resources, good advice, keyword being good. And all of it meant a lot. And I just want to say thank you because I don't know if I've had the opportunity to say that recently.
Oh, what a nice way to start a podcast. Look, I mean, as you can imagine, hundreds of startups cross my desk in any of my walks of life, and I don't do that for all of them. So I'll only get behind the ones who I actually think are going to make a dent in this world and bring something new. And as soon as I heard collaborative health record, you had me at hello.
Yeah. And I also want to point something else out, which is that, you're a force within the health innovation space. You have a fantastic platform, and I know you speak quite routinely about the future of healthcare and specific, as a health futurist. And I think one of the reasons in particular I enjoy talking to and also hearing you talk, and this probably resonates with other people as well, is because a you say it as it is, which I think is important. And there's a lot of topics and subjects that I find people kind of dance around when it comes to healthcare, and you sort of take it right on, which is an important piece that we'll probably talk about. And then the other thing is that you actually provide a vision, and a compelling vision, which is something we don't often see enough of in healthcare. So that's why I'm excited to have this conversation.
Yeah, north of patient, right? That's the vision. So we're getting at the same endpoint, but through different means.
Absolutely. So maybe right off the bat, do you want to let's talk a little bit about your actual career journey. What does the road to becoming a futurist look like? And what is life like as a full-time healthcare futurist?
I mean, I'm sure like every guest you've had or everyone you talk to, there's no way anyone could say, I'm going to do this in 10 years. You kind of just fumble along and stuff happens. I'll just fully, disclose. I made up the
Yeah.
title Health Futurist. I think my last 4 jobs, I decided the job and the title. So I think that's the one thing that I find in even medicine and healthcare, people think that there's these locked in journeys and then that's all it is. Like, no, 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 no. Like that's gonna be the minor thing, the new thing. So that would be my journey at a high level. Second point is in hindsight, if I look back at every choice I've made, even back to grade school and what I was drawn to, and at the end of the day, what work I did, the common thread I can now say now that I'm 50, there's no way I even knew that even 2 years ago, is I love to solve intractable problems. That gives me my buzz. And so I happen to allocate that capacity to the hairball of health and care. But if certain things would have happened when I was a child in a different path, I would be in climate right now,
Hmm.
or disruption, or poverty reduction, or something else. It's just that's my common thread. So just quickly to connect the dots, I'm a daughter of immigrants from Lebanon. And as you know, I think you might be from an East Indian
Hmm.
background. So if you're East Indian, I find Arabic or Asian, you know, you have three choices as a kid to make your parents
Yep.
happy: lawyer, engineer, or
Yeah.
doctor, which is
Oh,
Arabic.
as was an artist on the list? No.
Well, I have a sister who's an artist. That did not go well.
Yeah.
And so, my dad suggested I get into be a doctor. So I did. Like I just studied biology and like you had A pluses and was really smart and got into all these med schools. And then in the interview process, I realized I have no desire to heal anybody physically, emotionally, none of it.
Hmm.
So that's like my first time being honest about my career. So of course, when you don't know what you want to do, you just do more school. And if you're pretty smart, it's easy. So I did grad school. So the point is, I did a PhD in kind of diabetes research, biochemistry at University of Toronto, Faculty of Medicine, basic science, and similar. Just like I didn't want to be a doctor, I had no desire to be a scientist at all. And I'm like, oh my God, I'm just at 5 years. So I just got lucky that from there, I got recruited to Boston Consulting Groups. So again, I was like a doctor
Hmm.
for business, for really complex business challenges. Sometimes our client was an entire country. So it's not just for profit. So I think that's where I kind of had a place to apply this problem solving methodology for really messy, complex things. And then because I knew a little bit about medicine, I just gravitated towards the healthcare space. Really, that kind of set me up. And then a client was in the health innovation space at a time that nobody in Canada was doing startups and tech and innovation. It just wasn't a language in our lexicon because
Hmm.
Canada's generally 15 or 20 years, I'd say, behind
Yep.
on most things. So I just got, at Mars, which was the epicenter of health innovation. I led that platform. And then that led to a bunch of other things. And then eventually I emancipated from the word innovation to more futurist because I realized, just like you with what you call vision or go north, if you don't start with a working picture of the way the world might evolve,
Hmm.
there's kind of no point to making any decisions right now. And that's basically what I do.
Yeah, that's excellent. And maybe let's double click on the word futurist because there was an interesting intersection that happened actually in the first episode of the very first podcast that I did for North Patient. I had Julian Bleeker on, and we were, and he's also a self-described futurist, but he mentioned that the word futurist is a loaded term. And the moment he said that, I was thinking about you actually, and I was curious
Yeah.
as to what do you think about that, and also well, in terms of the actual word futurist itself, does it mean an expert? Does it mean being right? And yeah, I just wanted to unpack that a little bit.
So I would agree. I think I'm early, and so is him on this curve. So kind of like innovation 15 years ago, there was very few chief innovation officers. Very few health organizations had an in-house innovation something unit, center, office, whatever. And then it became this loaded word. Innovation theater we talked about, and everything's innovation. And so that's why I kind of don't like that word.
Mhm.
And so I self-describe myself that when my first role being, let's call it a chief innovation officer of a large complex health org back in 2018, I'm like, no, I'm not going to be innovation because you're going to put me in this box and I want to be this. So I called myself a future strategist, not a futurist.
Mhm.
Anyway, the point is, I think people think of futurists as these academic types of futurists that predict the future
Mhm.
and are pretty dogmatic about how that future will play out. That's not the kind I am. So if you look at my LinkedIn profile, I call myself an applied health futurist. So my take on futurism is more of um, I wake up every day and have a constant working point of view of how the future might unfold in health and care across all of it, every sector, every subsector, every profession, every disease area, every geography. Like that's what I do all day. So that then when I work with usually an organization level,
Mhm.
rarely at any, I can then help guide them how to either make choices today that are consistent with the ever unfolding future, or maybe make bets today that might accelerate the future they want,
Mhm.
or make bets today that get them on a path against the future they don't want.
Mhm.
So that's what I do versus pontificate, predict. That's There's a role for that, by the way. That's just not what I do.
Yep. So you're not sitting in an armchair looking at the window, kind of twirling your hair and, and then like writing musings down about what's happening.
No, but the work of the people who do that, there are a few good medical futurists, informs my work. No, I don't have to do that. So now I can go and say, okay, I'll just give you an example. Like I did a futurism session with a small community hospital who had no exposure to this way of thinking. They're just waking up every day trying to solve, all the crises of the day. And after an hour of just playing and hanging out in some ways things could play out, they concluded without me saying anything that this new medical tower that they were about to build and raise hundreds of millions of dollars for, they don't need to build anymore,
Mhm.
right? That's applied futurism.
Got it. And yeah, so so would you say to a certain extent it's less about a prediction, more about bringing facts that people are perhaps not exposed to, realities that people aren't exposed to because they're in silos? Is that another way to look at it?
Uh, Part of it is because they're in silos. Part of it is there's just no space to explore how things might unfold. So if you think of it, the way you could do strategy planning, pick a word,
Mhm.
right? How do you decide how you're going to allocate very scarce resources when there are 1000x priorities for what you have capacity for? And goodness knows there's so much in health that you could do. So how do you decide? Well, the dominant model is strategic planning, where you look at the data of today, you project it forward, you look a little bit back at history, and then you make some choices, right? Futurism says, I'm going to add another layer to that methodology. That's important. That's present forward. Is I'm going to look out and see if things play out in this different way, or pressure test this strategic bet I would have made and say, is it going to help me get there? Is it going to work against that? So that's all. That's the difference. And it could be because of silos. It could be because they don't have language. They don't have the facts. But most of the time, it's just a little bit of space. And so one, I don't know if the word is bandwagon. That's not the right word, but you know what I mean, that I'm on is uh, every organization in health and care, whether you're a hospital, a pharma company, a payer, will have in-house futurist expertise. Sometimes they'll build it all in-house and create a futurist team like I did at my health org and have a futurist and a team of blah, blah, blah. Sometimes they might outsource it. So there's a huge proliferation of futurists in residence.
Mhm.
For all intentions, I am a future in residence at Deloitte. I'm a day a week
Mhm.
in the healthcare practice at Deloitte versus an entire team. Sometimes they'll do that by doing a board education event or like that half day session I did with that hospital. So the more like in sporadic.
Mhm.
Sometimes their top clinician who's gonna, make it up the ranks to be the CEO is gonna go off and do a strategic foresight masters,
Mhm.
at a university. Like there's different ways you'll build this
Yep.
capability, but everybody is gonna have it and more and more. I'm gonna predict.
So when you're thinking about what's happening next, what would you say your sources of inspiration are? Who is inspiring you, or what is inspiring you right now?
Oh, there's so many every day because that's why I get to hang out in the future. I'll just do
Yep.
a few. I'll start very macro and then we'll get down.
Sure.
Kaiser Permanente announced the first ever Center of Excellence for Food and Medicine.
Hmm.
Interesting. Everybody's been talking about food and medicine. Even Kaiser as a health system, so it's the US based health system, maybe 13 or 14 million members.
Mhm.
They have already done a lot of investment as a business model in food security because they know that the reason people are visiting their medical system is because they're food insecure or the quality of the food isn't good. So they're like, if we're in the business of health, we got to be in the business of food security. But now they're creating a center of excellence. Like that inspires me because that to me captures what's been talked about for decades in medicine and healthcare about pick a lingo, social determinants, upstream health, drivers of health, whatever you want to
Mhm.
call it. But the end of the day, the reason we have a healthcare system is mostly because of what people eat and other behaviors around diet, sleep, stress, alcohol, smoking,
Mhm.
mobility, which then drives 85-90% of the demand for health services. So, but to see a formal sick care system actually create a new system of health creation to me is very inspiring. And I think that's going to raise the boats and create infrastructure that everyone else will follow.
Mhm.
So that's an example of a recent. I've got so many,
Yeah.
but
Actually,
you can bring
yeah,
in more.
I'd like to dive a little bit into that one because it ties into a conversation that I was having with some colleagues who I'm often on a chat with, talking about where things are going in healthcare. And one of the fundamental points that I was trying to defend was I feel like in so many ways, health systems today aren't really aligned or incentivized to actually eradicate these problems, right? And when we talk about that in different ways, we say, the sick care system instead of the healthcare system. But the expression that I really liked using, and I'd be curious to hear your thoughts on this, is that the system is designed to help people, not to eradicate the need for help.
Yeah.
And to a certain extent, actually, to take that one level even further, I feel like so many people who go into healthcare don't necessarily know that this is kind of a recurring business model that's sort of set up, and obviously no one's intended it to be that way, but it's the nature of such a large machine. And I actually think that one of the deeper causes of clinician burnout, job dissatisfaction, is probably the subconscious realization that the system isn't actually set up to be able to help people.
Yeah.
Yeah.
Moral injury,
Yeah.
right? Moral injury. To me, it's no different from school teachers.
Mhm.
Like they went in there with a benevolent intention to, change these kids' lives. And then, they trained for that. And the system is not set up to maximize that. And that is really hard to take,
Yeah.
right? So I agree. I think there are some nefarious agents that actually literally will say, prevention is a business model killer.
Yeah.
So let's just exclude those as let's call them edge, even though they're not edge
Mhm.
in some parts of the world. But absolutely. I mean, we built a sick care system for all the right reasons, because when we built most of our modern infrastructure post World War II, we had a very young population,
Mhm.
pretty healthy.
Mhm.
There were no tools or technologies,
Mhm.
and we didn't have the population size or the longevity. You
Mhm.
died or you got better. There was no staying alive with cancer for 20
Mhm.
years. So, I mean, so I think some of it is it's understandable. I'd say where the gig is finally up, though, is if your mission is health, whether that's your personal mission for your career, whether that's your organization mission, whether you're for profit, nonprofit, whatever, I don't care about your corporate structure. That transition is now, I think, happening with some real momentum of then I'm going to use the levers I have and the capabilities that I have a reason to have expertise in. As an org, I'm going to use that to drive health, not reimbursement for procedures. So that's to me this Kaiser example, and I'm starting to see. Used to be like in my slides when I talk about this, I'd have one story. It's now becoming pretty common, and I'll just put a little Deloitte hat
Mhm.
as because we have a whole future health point of view that's we've been evolving since 2018, and we just published it for Canada in early April. Um, we're actually starting to see the business models shift where if let's say you're a sick care enterprise, whether you're a single shingle primary care practice running as an enterprise or, a hospital or whatever, taking apart that business model, putting those resources into some upstream driver to, in theory, put out of business the sick care business, but they can make a viable, sustainable go of it in this upstream health place. That's starting to get some good groundswell, which is really exciting to see. And it's, in my view, the only way out of our ability to get equitable access of care to people. That's the only answer.
So to take that a step further, then is it safe to say that you think that the traditional players in the healthcare system, the hospitals, the health networks, they have an ability to make a lateral movement from sick to healthcare?
Absolutely. And some are. Of course, there's always early leaders,
Mhm,
and then others catch up.
mhm.
But absolutely.
Okay. So without delving too far into the pontification of it, to what extent do you think it's going to be new enterprises, new systems that begin to play, take a piece of that pie in this overall thing that we call health versus traditional players that have been able to make that move? Do you think it's kind of like a 90% traditional? Like, what does it look like in
Yeah.
the not
So
very
we've
distant?
actually modeled this with actuaries at Deloitte. We've modeled these shifts.
Mhm,
So there's two shifts happening of what I call value pools, which is a nice business word for like dollars,
mhm,
like where the investments will be. So one is definitely in sick care, and this is in our future health analysis. The incumbents that delivered services and got paid in certain channels, which we've been pretty mono channel. It's been very place based. Hospitals, clinics, nursing homes, a little bit of community, pharmacy. We've modeled about 80% of that will move to new channels of accessing, again, sick care services. So as an incumbent, if I want to stay in the sick care place, which there's always going to be a need for,
yeah.
let's be clear, I have no choice but to reinvent my business model anyway, because where people will access those services is gonna shift mostly out of hospital and clinic. Nursing home, we've modeled, stays pretty flat because there'll always be a need for that site for some people. So you need to reinvent your channel mix either way for sick care. One, two, the pie of, let's call it the whole health pie,
Mhm,
grows out to 2040. We've modeled that, but the sick care part stays flat.
mhm.
So all the new pie value is in prevention, primary prevention, secondary prevention, health creation, proactive health, not reactive, all that blah, blah, blah. And so who will accrue that value
Mhm.
is mostly going to be new participants, although some incumbents will grab a piece of it. Like for example, this Kaiser
Mhm.
example.
Yeah, that's a great way of putting it, and I think that's really helpful to also see that because one of the things that one of the anxieties I can say that a lot of people in healthcare right now have is there's an absence of being able to understand where everyone fits into the picture and being able to segregate kind of what really is sick care, acute care, reactive care, whatever you want to call it, versus all the other things that you can call the new frontier of possibility. Helps them see where they fit in, and also I think can help people make decisions around: did I sign up for this to be in camp A or camp B, and how do I make a
Yeah.
shift from one to the other, or that kind of thing. It's helpful to
And
see
I'd also
dynamics.
I'd also say it's not even binary. It's kind of like these binary conversations of, oh, virtual care or in
Yeah.
person, and it's all or nothing, or it's one. It's like it's never that.
Mhm.
Everything is a segmentation. So just to give an example of that, let's say you're an incumbent, you're in some your community-based hospital. Okay. You've got, tier A and B type services, a little bit of outpatient, and maybe you have a center of excellence regional for stroke care. Let's just put that out there.
Mhm.
Well, maybe as you evolve to the future of health, you do become the center for stroke care, which is an acute service. It's got a lot of pieces, and you are the node of that ecosystem for that condition, maybe for that region. But you're like a dot, and someone else is the node for maternal newborn,
Mhm.
for thoracic surgery, for whatever else. Like that's this new de-averaging where you might be the incumbent and the node and the leader, but for 50 other things, you're just participating in someone else's ecosystem.
Hmm.
So this is this new world of splitting yourself up and playing like are you the coach or are you the player? Depends.
Yeah.
So, and that's we're not good at that in healthcare.
Yeah, no, for sure. But I think thinking about all of the possibilities in terms of new frontiers is also super interesting, right? Because I think there's such a broad range of possibilities that really stretch the imagination in terms of what we call quote unquote healthcare, right? Where right now, we're so fixed in thinking about things from the perspective of obviously disease. But some of the interesting things that I've been seeing obviously are around artificial prostheses relating to augmented functions. So having a sixth finger or whatever the case may be, obviously being able to enhance the capability for what people are doing. You've probably heard about this, but Peter Thiel and some other investors funded this competitor to the Olympics, except that it's a everything goes. So it's like all human,
Yeah. Yeah.
biochemical and kind of physiologic augmentation is possible, and let's see what the human body can achieve,
Yeah.
which is
Yeah.
like it's completely out there in terms of thinking, but I think we have to embrace the fact that whether or not every single person uh, wants to or doesn't want to be part of that, there's a certain reality of the fact that humanity will progress and will begin to experiment and will begin to push the boundaries of what we consider human
Yeah,
or not.
and I think as much as we wanna sit in judgment of them, be like, "Oh, that Peter Thiel, all these big bro billionaire." At the end of the day, these extreme things that you and I be like, "There's no way," is why we have everything we have. Like, that's military, that's DARPA, that's how we got the internet, that's how we got penicillin, that's how we got rubber,
Yeah.
space now, like, we had to 3D bioprint insulin to be able to let an astronaut get their insulin if they're in space.
Uh-huh.
So then, so I think these like we'll call them harsh environments. Necessity breeds innovation, and then we all benefit. And I would say, even uh, like look at when what's that called when you have an ear implant?
The
What's that?
cochlear implant. Yeah.
That's our first cybernetic. Like
Mhm.
that's a human machine interface. You're a robot. You're.
Mhm.
And we didn't go like, "Oh my g" why? Because it actually helped somebody do something that they couldn't do the old way. So I think like exoskeletons for like an old person with mobility, well, sure, that technology will be used to power the next super NBA athlete in the alternative NBA.
Yeah.
But so I think we already do that. I think it's just not in our face as much
Yeah.
as, the modern era.
Yeah, there was a really interesting film I saw. It was called Ship of Theseus. I'm not sure if you've heard of it. It was like one of these small independent films. It was at TIFF a few years ago, but it was very thought provoking. Without giving too much of the premise of the movie away, it's based off this Greek story on the Ship of Theseus, and the idea of the Ship of Theseus was that there was a ship. They were replacing parts of the ship because it had aged, and as they'd replaced more and more of the ship, it got to a point where basically every single wooden plank on the ship had been replaced. And then whatever the person looks at the ship and says, is this still the same ship? And so this movie explores that, but from the perspective of organ transplantation. So,
Yeah.
at what point, if you've had your heart replaced, your liver replaced, your eyes replaced, at what point are you still the same person? And what point are you something different? Maybe like maybe a hybrid.
Well, I mean, Puneet, I'm gonna go like let's get a little bit more meta. Every cell in your body right now
Mhm.
wasn't there, depending on the cell,
Yep.
an hour to 7 years ago.
Yep.
Okay.
Yep.
So I'm 50. Not a single piece of tissue in my body was with me when I was born.
Mhm.
Maybe a couple ovaries are
Yeah.
left. Okay. So what am I? What are we?
Yeah.
Right?
Yeah.
Like nothing is still the same. So yeah, you know,
Yeah, it's crazy, and actually, I think the intersection of that with kind of the microbiome and obviously the study of bacteria in the human body is such a fascinating area as well. Because again, as you know, there's more bacterial cells in the human body than human cells.
not just bacteria, fungus
Fungus
and
and
virus.
virus, yeah. And so, but
Yeah.
that kind of makes us think. So, when you take antibiotics, to what extent are you changing the composition and the functioning of your body? Like we don't really we don't understand these things, and obviously, I say that not to say that people shouldn't take antibiotics, but I think it speaks to the infancy of our understanding between the human body and the things we do to the human body. And yeah,
Yeah, like, yeah, I forget the data point, but yeah, on a percent of tissue in our body, the amount that is these other agents is far, far in excess of human tissue.
yeah,
So who really calling the shots around here?
yeah,
And then of course the data on the gut brain axis is getting better and better. My let's call it prediction, or well, not just me, some of the top experts, just like you said, like basically, if you think about it in medicine, as we found out about yet another organ that's failing, we made a special nephrology,
yeah,
endocrinology, orthopedic. Like we made, as we found a disease, as we found a body part, we made a disease, we made a medical specialty.
hmm,
The taxonomy of disease classification was like this very human
yep,
mess.
yeah,
Like, are we kidding ourselves?
yep,
So, like, the one that baffles me, because my PhD was in diabetes, is around like type 1 and type 2 diabetes. Maybe we're talking about a type 3 right now
yeah,
that's got some correlation with dementia. Are we like really? If you look at the data, let the data tell you
hmm,
what these factors are. There's 1,000 diabetes out there
hmm,
that would have very different treatment paths
hmm,
and prevention paths
hmm,
than this reductionism of 3. So this is where, if everyone asks me, like, what's the one thing that, could be the biggest lever to make health better for everybody, it's everything with data.
yeah,
Everything with data. Like we are like a little hut in a desert of our
hmm,
potential.
yeah,
And I think we're gonna really look back. It's gonna be like bloodletting, or putting people in a polio chamber, like
yeah.
what we do today.
100%. And it's hard to imagine that, but for sure. I mean, taking that one step further, and I completely agree with you. I think the reason why, again, people feel, and by people, I feel the general public, when they're accessing the healthcare system and kind of being sent, okay, well, spoke to the cardiologist, they said this is not a heart problem, go here. Spoke to the, nephrologist, they said this is not a kidney related problem. And the limitation that people experience from the fact that we have built a system based on the way we, as you said, the way we studied the human body and discovered it led to the way we actually think about the delivery of healthcare, which makes no
Yeah.
sense because we are a sum of all those things, and all these conditions are a sum and experience of all those things. But I think with the interesting thing, yeah,
I'll just add on there, and then you'll go to your next point. And
yeah,
um, because we run a labor intensive model of care, right? 75% of the whole envelope of healthcare is labor. We have to timeshare the best expertise. So that cardiologist, then the endocrinologist, then the nephrologist, and the patients, to timeshare that expertise, you got to go back to your primary care, get a referral, which is sent by fax machine to go to that next specialist, wait 6 months for that appointment, do all the tests, conclude, no, you need whatever ist, come back to primary care, get the next referral, right? Like that's why some conditions for patients take 12 to 20 years to diagnose. It's nuts.
yeah. It's wild. No, yeah, no. I was saying all this to kind of get to that point of the fact that when we think about how we, as individuals experience and access care, and we realize that we're kind of being sent in different directions as we try to pursue the understanding of what's happening to us. um, I think we also have to think about, to what extent are the systems and institutions in place equipped to be able to inherently evolve, right? And one of the good examples, and obviously I think the cornerstone of this issue kind of comes down to medical schools. I'm sure both you and I have conversations with medical school program directors and kind of people in different parts of the academic system. But what do you find yourself telling them? What do you want to be able to say to them to
Yeah.
say,
Oh,
this is
okay.
how,
Now I'm going to propose.
yeah, go
I'm
for
going to
go,
propose.
go for it.
Big warning on the fun. First of all, that statement that, you're saying, I wonder if our systems can evolve. I'm going to tell you the answer, Panit. No,
Yeah.
they can't. Because particularly in public goods, we've institutionalized. And what is an institution? Look at like Catholic healthcare, Catholic church. An institution never goes
Mhm.
away. like it's, you know, so, and, you know, if you look at in the business world, Christensen and others would always say the worst place to create a new business model is from within a current business model.
Mhm.
That's the same as evolving a system. We're just not using the word business model,
Mhm.
right? Business model is just what do I do and how do I get paid
Mhm.
to make it economically viable? That's all it is. So it's almost impossible for a complex system, whether you're, you know, again, a whole system, a hospital, it doesn't matter, to self disrupts itself. It's like so against all human nature. So it's not going to be likely. There'll be the odd one, but not the default one.
Mhm.
Um, so then what do you do about it, right? How do you get through that? And that's where um, we will go to other sources like to get what we need done. And it's going to be okay.
Yeah.
Uh, Most of what we need in health and medicine, we don't really need the kind of infrastructure we've got set up for it today, in my view.
Yeah. And I think that that's a hard pill for many
Oh, I
people to
didn't answer the
swallow.
med school. Sorry.
Pardon?
Yeah, sorry.
Yeah. So,
The
so
med
if you
school.
had to say something
Yeah.
practical to,
Yeah.
program directors,
Yeah.
people in the academic community there, what would you say about what can be done with the resources and the structures that are there? What can they do that's
Yeah.
productive?
I'd say stage one is just very, very rapid curriculum redesign. So when I worked at a medical school in the Netherlands, we were changing the curriculum, Vinny, every 6 months. Okay. Every 6 months. And that's probably too slow,
Mhm.
but I remember trying to change the curriculum in a faculty of medicine we both know and love.
Mhm.
12 years.
Yeah.
So I think that is one of the kind of an ability to really. It's kind of like how in Canada we call them colleges, like vocational schools.
Mhm.
I know in the U.S. college is like what we call university, but anyway, like they're constantly keeping their pedagogy, their program, their curriculum up to date for what the market needs.
Mhm.
That's to me what is needed. But the next layer of medical education will be you might do, I don't know, a year in some kind of a formal institutional, and then your medical education is at the point of care. It has to be at the point of care.
Mhm.
That's a very different approach that you like play it out.
Yeah.
What does that do to so many things?
Yeah.
I don't know.
And I mean, I can imagine the challenge that program directors might say then as well. We have to be accredited in order to be able to get funding, and then the that process in terms of the governing body that's looking after those programs is the one then that needs to change because otherwise we're not even recognized as a medical program. Let's say, for example. So then you kind of begin to follow that trail, and then you get to institutions and organizations that are again more and more steeped and entrenched in legacy and institution. And then then what do you say to them, right? Do you say the same message, which is that okay, we're going to evolve and iterate? Do we sort of say, can we take a step back and just ask ourselves, what is the role of the human being in the process of care delivery? Where are we adding value today, 6 months from now, a year from now, 2 years from now, 5 years from now, and can we then have some type of an evolving roadmap? Like, is that what you would say, or would you just, yeah.
100%. Like one other thing I provoke with, I just did a session with the School of Nursing, and I said, there is no more role called nurse.
Mhm.
Right? Like we've put people into these the job as the structure, as the construct, the currency, right? Again, and we're the most labor intensive sector in the world. And our currency of the labor is job.
Mhm.
And the job is tied to credential,
Mhm.
very narrow credential that's regulated, blah, blah, blah. There is no more nurse. There are people who perform nurse like duty.
Yep.
So replace nurse with physician, with whatever.
Yep.
Doesn't matter.
Yep.
Like, so this, it's called the adaptable health workforce. And I'll just kind of quickly, if we want to frame it, if you think of, let's say there's 100 units of capacity of, let's say, a person called a nurse with
Mhm.
a narrow credential,
Mhm.
again, or nephrologist or physiotherapist, it doesn't matter. Of the 100 units, there's different math, but I'm just going to be conceptual, but not that conceptual. About 30 to 40% of that time that they're using, that we timeshare, right? We pay on the hourly labor unit. 30, 40% not necessary, wasteful, duplicative. shouldn't be done.
Mhm.
Okay, there's 70% for you. Okay, now what's left, depending on what it is, what tasks, cognitive or automated for robotic or human physical tasks, 10 to 30% can just be done by a machine.
Mhm.
Okay. Then your next chunk. So I'm just taking the 100 and breaking it into four. Your next chunk is tasks, not the whole job. Some of the tasks could be done by another type of trained professional
Mhm.
or upskilled professional. So, for example, in the UK, when they needed to jab their highest priority population with COVID, seniors,
Mhm.
they upskilled 70,000 civilians, taught them how to jab, cleared that, and then they went back to their jobs. And then we went back to nurses and doctors jabbing you in your arms. Okay. So
Brilliant.
so it could be another professional. That's nurse practitioners doing some portion of primary care. That's pharmacists having powers. And even in Ontario, we just approved nurses to have some kind of primary care role. So that's what I mean. That's this adaptive workforce. And then what's left, and depending on the fixed credentialed job, could be 10%, it could be 50%. Maybe if you're a neurosurgeon,
Mhm.
you're not going to upskill a volunteer from church.
Yeah.
Um, is what that licensed, credentialed, trained profession needs to do. So play that out of all the work. If you uh, disassociate it into those parts and put it back together,
Mhm.
what we could be doing. But then you say, okay, that's a great desk exercise.
Yeah.
What happens to everything else? I have no idea.
So, I mean, if we think that through and we think about the fact that right now we have these separate professions, separate titles, pharmacy, nurse, physician, allied health, so on and so forth, as separate colleges even, then would it not make sense that we really change that structure, combine it
Yes.
into something that's governed together, and then says, okay, well,
Yes.
what do we know about all the different activities we do, and let's think about how this is going to change over time, and we don't need separate institutions to do that. That would that be like a more logical, possible way to do?
That makes sense, and that's exactly and that's what and everybody is in violent agreement, that's kinda what we need to do, but they don't know how, and I wonder, and I haven't thought it through, maybe a listener can what is an analogy? What's another either public good or service thing where we credential people to death in an industrial context? We've industrialized medicine, but now industrial doesn't make sense, now we're in a solution economy. I don't know where the
Yeah.
what the parallel
Maybe in
is.
manufacturing, maybe back in the day, they probably had different types of people doing certain technical jobs in manufacturing, and some probably involved more and more technical work with machinery. Some were probably a little bit, had simpler, repetitive roles. And I wonder if that evolved over time as the machines evolved and all that. And yeah.
Sure, maybe. That might be one to look at. So I agree. And so and then your head hurts because you're like, that's like a redo of everything. And so two ideas on that. So again, one way to get at that I'm seeing happening is being like a little half pregnant between the two worlds. So that's things like what we were doing in Netherlands, changing the curriculum every 6 months. It's not going to solve world peace, but it is a pretty good start compared to teaching you something that's gonna have absolutely no relevance
Mhm.
by the time you graduate. Another version that we're seeing a lot is, new med schools are popping up. I think we're in our fourth in 2 years coming in Canada. We haven't had a new one in
A long time.
50 or 100 years. Um, that are by design, because instead of undoing an old medical school, which is really, really hard to do, they're designing from day one, at least for a little bit more of the future. So, for example, when Dell Medical School started in Austin, Texas, again, Austin got to be a million people. A million is about the right number of a population to warrant having a medical school.
Mhm.
And so they built a new medical school from scratch. And the new dean was like, I can do more here to build it from scratch for where medicine's going instead of trying to be the dean at my old medical school and undo all the patriarchy
Mhm.
and things. So, for example, in that case, other orthodoxy that they smashed that most medical schools are still doing, they don't want the A plus 98% student because there's no correlation
Yep.
for what medicine means. So you apply as a team and you interview as a team.
Mhm.
You don't interview as as an individual, as an
Yeah.
example, and many, many other things. So that's one version. The other version is to blow it all up and start with a clean sheet of paper. That's where places like Saudi Arabia are doing. They're
Mhm.
literally building a healthcare system from scratch.
Sure.
Except what they have is unlimited capital
Mhm.
and a boatload of ambition
Mhm.
and a population that's extremely at risk for cardiometabolic illness because just I'm Arabic, I'm Lebanese.
Mhm.
The genetics are very bad
Mhm.
for our current obesogenic diet
Mhm.
and lack of
As they are for South
mobility.
Asians. Yeah.
And for South Asians. So
Yeah.
it will cripple their whole country and, just on kidney failure and all the consequences. So you've got a bunch of forces that are saying, there's no way we're going to 19th century medicine our way out of this pickle.
Mhm.
And they're being ambitious about everything. They built a space program from scratch.
Yeah.
They're building a city of the future that's kind of net zero on carbon. So there is that. And then I think one way I'm starting to play around with, like, how do you do this? Like, it's so hard is, for usually if it's a public good, government is your governing entity that can at least pull some of these levers to change things. It's rarely like a hospital
Mhm.
or is a new office of government called the Office of Transition,
Mhm.
not innovation, not transformation,
Mhm.
transition. We're transitioning to a new world, a new economy. And you need a methodology to transition that's explicit,
Mhm.
explicit. And that's not just transitioning, let's say in healthcare, but transitioning to a low carbon economy, transitioning to a digital and data society,
Yep.
to a mobile society, like all these transitions. That to me is the next unfinished business.
Yeah, no, I think that's a really interesting perspective, and I like the idea that it ties in with the fact that healthcare is not something that's going through change in isolation. The entire world and every institution we have and every way of doing thing we have is evolving, and how do those pieces impact one another, and how can we actually leverage advances, learnings, changing from one place to the other, and how do we make sure that things aren't working counterproductively? Um, and I want to point out an interesting thread that's come up in these conversations as well. So you're the third conversation I've had where it's kind of come down to this idea of the lack of alignment between educational systems in general and this idea of job, and the idea that we now live in a world where, generally speaking, people think that the goal of higher education or education in general is to get you a job as opposed to provide you with the ability to learn, to expose you to skills and skill development, to hone your intelligence and your capability, and then let you become a productive, functioning, capable person in society. And
Yeah.
and this ties obviously with healthcare, but this affects obviously every other part of society as well.
Yeah. So I co-lead for Deloitte in Canada in healthcare, our future of the health workforce
Mhm.
signature issue, which is really interesting because the future of work, what you're saying, is going through a massive thing. Jobs are dead, right? It's workforce ecosystems. There's so much going on in the future work for all work.
Mhm.
And then the future health is going through a thing. And at the apex is the future of the health workforce. But why it's so more profound than even, let's say, the future of work and the future of education, or the future of work and the future of retail,
Mhm.
is because of the labor structure of healthcare
Mhm.
is so labor intensive.
Yeah.
And we haven't just locked that labor into jobs
Mhm.
like everybody else has, but they're jobs that are credentialed to death
Mhm.
and regulated by a regulatory college.
Mhm.
So there is really no flexibility.
Yeah.
So you think about it, we've got the most static infrastructure you could imagine to deliver healthcare in two formats:
Mhm.
labor in fixed jobs
Mhm.
and buildings.
Yeah. Yeah.
The most static infrastructure for the most dynamic service you could imagine.
Yep. Yep.
And this is the future.
Yep. Yeah. And then then it should be surprising that even the most basic things like communication and the transmission of a request for a service or referral become systematically complicated to do because everything is locked into things that just aren't able to change. Um,
Yeah.
so I want to take things in a slightly interesting direction, diving deeper into this idea of the human beings and care delivery. And this is something I've been thinking a lot about. I don't have all the answers, but I I'm really interested to hear your thoughts on what role you think human beings will really be playing in care delivery in a not so distant future where AI is commoditized. It's become a functional and accessible part of society and the healthcare system. What is it that human beings are bringing value to the table with?
So get back to my remember I took 100 units of time of any health worker, the humans of healthcare.
Mhm,
So yeah, 10 to 30% depending just can be done by machines and I think that's a great thing to free them up to do amazing empathetic
mhm,
human care. So I think when we come down to it at the end of the day um there's a lot more to care delivery than tasks.
mhm,
So sure, you need to put that IV into the kid's arm so they get their liquid, whatever. But there's what the human does, as you know, is connect all those dots and create the conditions and blah blah blah. So I think that never goes away in any service industry. However, let's step way back to what do we mean by care delivery? Okay,
mhm.
so language really matters.
Yep.
And I find people use three words interchangeably: health, healthcare,
Mhm,
and medicine.
mhm.
Okay. So health is the results.
Yep.
It's how I feel, it's how you feel, it's what we want. Um, it's not a service. It's not mediated by a human.
Mhm,
It's the result. Okay. Now, you and I, the average person, manages our health and creates our health all by ourselves. Thank you very much. We diagnose our symptoms, we treat ourselves, we figure it out,
mhm,
right? You wake up with a sore stomach one day. Are you going to go run a marathon that day?
mhm,
No.
mhm,
You're just going to chill
mhm,
and let it, wait, right? Okay. Healthcare is when we need to outsource our self management of health to a professional.
mhm,
It's a set of services mediated by professionals that use equipment and technology and blah, blah, blah.
mhm,
Um, so when I need to outsource my agency, I'm going to go now into healthcare delivery and access these services. And we have a contract and an insurance scheme that says I'm going to keep paying into a pool of money in the off chance one day I can't take care of my own health.
yeah.
I'm going to outsource my agency and it'll be there because I paid into it. Okay. Medicine is one type of way of doing care delivery.
Mhm,
It's a science, it's the dominant one, but it's largely based on doctor with a little bit of nurse, using technology, usually, at the time, drugs and,
mhm.
diagnostic tests and procedures like imaging. So such a narrow band, right? And so back to your question, I actually think, and this is this movement, and frankly, I think it is again part of the only way it's going to work will be to give back a lot more of the agency of decision making, of being the CEO of my own health,
Mhm.
way more to the people.
Yeah.
And some health systems have quantified that about 80% of what's currently done in healthcare delivery could be self managed by people in their communities. 80%.
Wow.
So so then what's left is the humans that are for where you really need them, either because I can't outsource my agency, maybe not today, maybe Monday I can't outsource my agency. I need to get the system, but maybe Friday I can. Like it's not
Mhm.
fixed.
Yep.
Then it's going to be doing the things that only humans can do, and letting either other less trained humans
Mhm.
or machines do the things that don't add as much value. That's the new composition.
I love that. Thanks for, it's helpful to go back to language because you're absolutely right. And I would say I don't recall ever in medical school actually having a conversation that broke down health versus healthcare versus medicine that way. So it's a really useful insight. But going back to that question of what is it that only humans can do? What is that? What do you think that is?
So generally, and this is some, oh God, I'm not to get his name, Jay Parkinson, I think,
Hmm.
if I remember
I'm sure
correctly.
about.
I like the way he framed it is now when you're outsourcing your agency into healthcare services, there's kind of this expectation of some, some core, let's say, universal principles of what is it? What are you expecting? Definitely benevolence,
Mhm.
right? Which is the intention of the human that you're outsourcing your power to because you can't do it yourself. Their intention is good for you, right? That's a core bedrock, I think, of the practice of healthcare, whether it's publicly funded or privately, it doesn't matter. But there's an expectation of they're doing it for your good, not for some other, you know, malevolent reason. Trust is a core bedrock
Mhm.
of outsourcing your agency that, you trust that they've read up on your history.
Mhm.
You trust that they've done all the right training and education to bring the best information to bear. You trust that that fax machine isn't going to go to the wrong digit on the phone number and get read by whatever, right? Like that's a built in, right? So things like that to me is at the heart of why the human is the mediator. Now, one way, again, I'll provoke.
Mhm.
I don't know that I have a strong point of view, but I really challenge these dogmatic statements that the core of this human role in medicine is the doctor patient relationship,
Mhm.
and particularly primary care.
Mhm.
I don't know.
Yeah.
I don't know. But people say that as if it's so obvious
Yeah.
that we have to keep fixing primary care ad
Yeah.
nauseum because we decided, and I don't know that good medical practice will be you having a one-on-one relationship with one person who knows your whole family your whole life.
Mhm.
I think there's a role for that,
Mhm.
but I think that's a big dogma that has yet to be unpacked.
Yeah, it is, and I think we hold it almost to like a spiritual status that there's this unexplainable thing that's just so visceral and so deep, and not to downplay the fact that there's obviously both in especially in historic context, there's been such an important role between the idea of, I think you can just say healer in general. Going back thousands of years, the healer in the community and the healer's knowledge about who you are. You have the trust, you have the benevolence, and all those things. That's very different from the lived experience of 80 to 90% of people, I'd say, right now in the developed world, in terms of the fact that they don't necessarily have that relationship. And I think this concept of benevolence, trust, even empathy, and not to the fault of any individual person, um, going back to this idea of challenging dogma, I really question this idea that empathy is only a domain that human beings can venture into. And
100%.
I get it, and I get that there are things to empathy that are beyond mathematical constructs and beyond purely biochemical reactions, but I think that we sometimes overvalue the or we don't pay attention to the fact that we're grossly underperforming in those human domains in the current status quo.
Yeah,
And
and I'd say I totally agree, and I think, again, I get back to, like, if I had a choice as a patient between timeless ideology.
Mhm.
So what I hear a lot about this argument of the patient-clinician relationship is the core, we have to make it right, longitudinal, blah, blah, blah. Um, that's the ideal,
Mhm.
and when it works really well, wow, does it work well.
Mhm. 100%.
But it's actually not possible, and not because of numbers. Because of everything you just said, right? So, do we want to therefore deny good quality care to almost everybody because we need to keep doing all the system change and writing more papers and having more conferences about how to fix primary care? Or do we find ways to get the result we want with what's available and what works? Just last thing on empathy, probably I just came back from the International Virtual Reality
Oh,
Symposium. It was
nice.
on Monday
Where was
in
that?
Montreal.
Montreal.
But we had Israel there, we had England, France, California, North Carolina. It was just great to spend a day at the edge of where immersive technology is going. And one of the things I didn't appreciate so much on empathy is So we are underperforming on empathy, mostly because, as humans in the digital era, we've reduced most communication to text, email, and this two-dimensional thing called video.
Mhm.
And then when it is in person, let's say in an in-person consult, what in a 15-minute consult, how much is retained by the patient, Puneet?
Mhm. Oh, like
15%?
max.
10%? So we have this unit is called the consult. It's the most inefficient, ineffective thing we're time sharing you. You're billing by the 15-minute visit and like 10% of anything that went down.
Yeah.
Right. And in that 10%, even how much of that was based on you, Paneet, having a real empathetic understanding of this patient in front of you, even in a life. So what virtual reality does is it adds a layer on this very devoid of emotion channel of communication called text, email, and video.
Mm.
And the biology shows this, like with Yale's done a study, like a two-dimensional video interaction, the neural circuitry is off. It suppresses your neural circuitry.
Mhm.
So what VR can do is one, recreate mostly what a three-dimensional in-person experience is,
Mhm.
but even more because it adds story.
Mhm.
So the clinician knows your story as a patient in a way that doesn't need an hour interview
Yeah.
to get yours. And story is how we evolved as a species.
Yeah.
So I think some of these new ways to amplify empathy on humans, I
Yeah.
think are going to be a game changer. And then I completely agree. A lot of these, and it's shown, it's
Yeah.
not just the fact, these chatbots or whatever have way more empathy
Yeah.
than humans
I
in many contexts.
100%. And I know that's going to be a provocative statement there, but I do think it's real. And I think there's another interesting reality that comes down to sort of our thinking and between yourself and myself and generational thinking as time is evolving. People who are growing up into a world where GPT-4 being there is all they've ever known. And I'm sure you've seen this. Like now people are saying, they've had emotional relationships with GPT-4. I found my digital girlfriend or boyfriend in that world, and I have this deep connection. There's people in parts of the world that are getting married to digital beings because they truly feel like perhaps because they were struggling with loneliness, they didn't have the ability to connect with people, or because of personal preferences, whatever the case may be. There are people that are increasingly demonstrating that non-human beings and humans are able to interact in ways that, quote unquote, are unorthodox from our definition of what is only a domain for human experience. And that's I think going to rock our world. And I often think about this idea. The thought experiment that I like is if you could take the historic top 99.99% performer of empathy as a human being, like the person who was just like a savant in empathy and
Yeah.
was just able to, within seconds, bring someone to tears, whatever the case may be.
Yeah.
And you were able to clone that capability um, and deliver that, you know, 24 hours a day, 365 days a year.
Yeah.
The moment somebody has trauma or sees something or, experiences something like profound, think about how much time is lost between that experience, that suffering that happens. You might have seen a car accident, and now what exactly happens, right? When do you see, a therapist?
Yeah.
Or maybe you're seeing them through a video chat. Is there human empathy happening there? That could be, but perhaps that isn't the kind that you needed. And now there's, this idea of something that's working to understand you that probably already knows about more about you than you know about yourself, that's now responding to you in ways that you would have never been able to articulate to a person. And that, like this kind of idea of like super empathy, and maybe this won't happen, but I do think that there's something to be said.
Dude, it's happening already. Like this is the thing, as you can imagine, when you and I hang out in this space all the time. So I was just at South by Southwest
Mhm.
in Austin. Like what you just described is there. It's just normal. I think similar to that, what you just described, I think the average person, particularly in the muck of healthcare, would be like, no freaking way. That's never going to happen. No, no, no. Let's regulate. That's your default. Well,
Mhm.
guess what? Remember when Orville Wright, was it? The Wright
Yeah.
brothers made an airplane?
Yeah.
You imagine if when we started using them, they're like, pretty soon this whole thing will be flown by machines and the pilot will be there, but won't really do anything. Would you ever get on your default will be like, no freaking way,
Yeah.
right? Then trains. You know the trains that go around Amtrak.
Mhm.
There's no driver of those trains. It's a machine.
Mhm.
But but nobody would get on one when they found out, right? And same with driverless cars now. So I think our default, all human nature, is to find complete flaws in what you just described.
Yep. 100%.
But then just if you hang out with this stuff enough, you're like, yeah, that's what's gonna happen.
So maybe that's a good segue to this question of what can people in the healthcare system today be doing to prepare for tomorrow? That's something I get asked a lot, and yeah, I'm curious to hear your thoughts. How does one hang out in the future, and what's the effective way to do that?
So there's a bunch of mechanisms. I started talking about a few of them at the beginning when you asked if futurist was a loaded word. So, like I said, I'm finding, and part of why Deloitte, brought me in this role is every single client of ours, and we work with everybody who touches everything in healthcare, private, for profit, system, local, not, you name it, all of it. They're all asking for this, some understanding, some sense making about the trends, the shifts, the future, um, for a bunch of reasons. And so that to me is the minimum that is pretty common. And if you're not doing that already, just have a way to get a little bit of exposure and understanding. Listening to these podcasts is great. Usually, you might bring in an expert like a me or a team, or and do a little bit of like live sessions. So I'm probably doing 6 a week now of these 3-hour future health sessions where we share a little bit and then we process it. And then we share, then
Mhm.
they're very common. Boards of directors are all requesting, educational time at the board meetings on the future. Future proofing is another loaded word. That's kind of the light version. Okay, the next version, whether you're in whole org or you're an individual working in an org or you're a student, is to just start to experiment and access it yourself. I mean, I don't know, Puneet, what your origin story is that led you to start a digital health company.
Mhm.
You're a perfectly good functioning doctor, but sometimes could be like you take a certain funky course, you do a hackathon, you might join a startup, if you're a doctor as a medical advisor part-time, you might do like a master's in entrepreneur. I don't know, but like I call it your side hustle time.
Yep.
You just, maybe you do a podcast. Like there's a bunch of venues and ways. Some are formal, some are informal. And then eventually, if you're good at it and you like it and you feel like it's feeding your purpose of why you're in this space, the curves cross.
Mhm.
And what was your side hustle
Yep.
becomes your major.
Yep.
And then, like, for example, most clinicians like you,
Mhm.
I think you still do clinical
Yep.
practice, right?
Yep.
Yeah. So then maybe you're in clinic 1 day a week, but you're not 5 days a week and
Exactly.
doing this other, so that's generally, I find how most people do it.
No, that's awesome. I'm cognizant of time, and I wanted to make sure you had an opportunity to say any additional thoughts, anything else you want to touch base on before we wrap up.
You know what? I've got like these little doozies of provoking around, like, is it really about primary care?
Yeah.
We're all that I rarely get to talk about. So to have the space to get it all out,
Yeah.
right, it's been very nice. So I don't know that I have much to add other than, really thank you for creating like this idea of north of patient, like a very different North Star. I do think we need some hopeful dialogue. It's too easy to obsess about the crisis.
Mhm.
So let's keep going, my friend.
Thank you so much, Dana. This was absolutely fantastic. I feel like there's so many more things to talk about, and maybe we'll have you back on and continue talking about those. I'm sure 3 to 6 months from now, a lot will have changed. So.